Hello, everyone. My name is Jouri. I'm a third-year medical student, and today I'm very excited to be giving you this session on the pituitary gland or the hypophysis. These are my details. In case you have any questions later on, feel free to reach out to me and ask me. Okay, so this is what we're going to be covering today. We're going to be discussing the anatomy and the physiology of the pituitary gland and all the hormones. Okay, let's begin with the anatomy. Firstly, the pituitary gland is a very small endocrine gland, the size of a pea. As you can see, it's very small. And it's located at the base of the brain. It sits in a bony depression in the sphenoid bone called the sella turcica. It's basically a depression in the sphenoid bone, as you can see here. And the pituitary gland is connected to the hypothalamus. It's connected via something called the pituitary stalk or the infundibulum, which arises via the median eminence. And basically, you can see here, we have the hypothalamus. This over here, these curves, I guess, this is the median eminence, and they join to form the infundibulum or the pituitary stalk. It's clearer here. And this is what connects the pituitary gland to the hypothalamus. All right, the pituitary gland is divided into two parts. We have the anterior pituitary, which is also referred to as the adenohypophysis, and we have the posterior pituitary, which is also referred to as the neurohypophysis. The anterior pituitary is mainly composed of glandular tissue, and its main function is to synthesize hormones. The posterior pituitary is mainly composed of neural tissue, so it's made up of the axons from the hypothalamus and not glands. And here, it doesn't synthesize hormones, but it stores and releases them later on for when they're needed to be used. So here again, we can see we have the pituitary gland connected to the hypothalamus via the infundibulum. We have the sella turcica over here, which is this curve holding the pituitary gland, and it's made up of the sphenoid bone. And below that, we have this little air pocket here. This is called the sphenoid sinus. Okay, so let's start talking about each subdivision. Firstly, we have the anterior pituitary, which is the adenohypophysis. It's divided into three parts. We have the pars distalis, which is the largest portion. This is the main part of the glandular tissue of the pituitary gland, and it is the main part that produces all the hormones. We have the pars tuberalis. This just wraps around the infundibulum, the pituitary stalk that we talked about. And the last part is the pars intermedia, which is just a remnant, an embryological remnant, and it lies between the two lobes, okay? Next, we have the posterior pituitary. Okay, so the neurohypophysis, it's made up of the floor of the third ventricle of the brain and the infundibulum, and this is what forms the posterior pituitary. Through this, we have hypothalamic axons passing down from the infundibulum to the posterior pituitary, okay? So like we said, we have hormones being made in the hypothalamus and they're being passed down axons to the posterior pituitary where they're stored and then released later on when they are needed. And the posterior pituitary has two parts. We have pars nervosa, which is just the main part of the posterior lobe, and we have the infundibular stem, which is just, as you can see here, it's part of the infundibulum. This over here is the pars nervosa, which is the main part of the posterior lobe, sorry. And over here, we have the anterior lobe of the pituitary gland. This big bulk over here is the pars distalis. This is, we said, the main bulk, it's glandular tissue. And we have over here the pars tuberalis, which is just wrapped around the infundibulum stalk. And in between the two lobes, we have the pars intermedia, which is just a connection. It's not very significant other than that. Again, over here, we have the median eminence. This is where the infundibulum arises. And we have the floor of the third ventricle. We said this plus the infundibulum make up the posterior lobe. And we have the hypothalamus. Now, let's discuss some of the anatomic relations of the pituitary gland. Superiorly, or on top of the pituitary gland, we have the optic chiasm, which is basically where the two optic nerves cross. And we'll talk about why this is relevant now. Laterally, on either side of the pituitary gland, we have the cavernous sinus and the internal carotid artery, and we have these cranial nerves. Now, these cranial nerves are relevant because these are important for the movement of the eye muscles. And below, or inferior to the pituitary gland, we have the sphenoid sinus. The most important one clinically is the optic chiasm. And why is that? Because if we have a tumor in the pituitary gland and it starts to grow upwards, we said that superior to the pituitary gland, we have the optic chiasm. So if this tumor grows upwards, it's going to start to compress that crossing of the optic nerves. And this is going to develop a condition called bitemporal hemianopia. What happens here is basically as the optic chiasm is being compressed, the patient is going to lose their temporal visual fields. So as you can see here, they're going to be losing the outer half of their vision, okay? These are my notes from first year from the same presentation from Dr. Yaqin. I put them in case you can use them. So we said the pituitary tumor will compress here. We see the optic nerves. They're going to cross and they're going to make the optic chiasm. So it's going to compress this optic chiasm and it's going to cause the patient to lose this part, the temporal vision, the outer half of their vision. So if this came to you in a question, for example, you're going to see someone that came to park their car and then they hit the sidewalk because they can't see it. Or someone is walking on the streets and they bump into a person on the side because they're unable to see that person. They've lost the outer half of their vision. Yes. As for the other relations, we said laterally we have the cavernous sinus and cranial nerves. So there can be involvement of the cavernous sinus, or there can be cranial nerve involvement where you'd see different manifestations with the eye. For example, you can have diplopia, which is double vision, or you can have ophthalmoplegia, which is weakness of the eye muscles, basically. And for the inferior relation, we said that below the pituitary gland, we have the sphenoid sinus. Why is this useful? Because when we want to have pituitary surgery, if we want to remove a tumor, instead of having to cut and, have a very invasive procedure, what can be done is we can get an endoscope and we can just put it through the nasopharynx, through the sphenoid sinus, and we can reach the pituitary gland without having any invasive procedures. So it's just much simpler access to the pituitary gland. It's non-invasive, it has higher success rates, less complications, and so on. This is the picture from Dr. Yaqin. I just put it in because I also had some notes on it. But like we said here, the cranial nerves that have to do with the eye movement, the pituitary gland, nasopharynx, and sphenoid sinus, which we use for the transsphenoidal approach for surgery. And again, the most important relation is the optic chiasma because it can cause the bitemporal hemaniopia. All right. For imaging, here we have a sagittal MRI. So let's go through it one by one. Firstly, this structure over here is the hypothalamus. As we go down to this structure, we said this is the infundibulum. We say the hypothalamus is connected to the pituitary gland, the hypophysis, which is over here by the infundibulum. Below that, we have the sphenoid air sinus. Just a general note to keep in mind, when you see something black like this, it's probably going to be air. Okay, so here we have this air sinus, the sphenoid air sinus, above it the pituitary gland, which is white. It's bright and white. So when you see an MRI like this, just keep in mind the pituitary is white. Below it, you'll have this big black spot, which is the sphenoid sinus. Last thing here, we have the nasopharynx. Okay, so superiorly, we have the hypothalamus. In the middle, we have the infundibulum. And inferiorly, we have the pituitary gland, sphenoid sinus, and nasopharynx. As for this MRI, we just need to know here we have the hypophysis. It sits between these two cavernous sinuses. And above it, we have the optic chiasma. Again, remember, if this is compressed, we'd have the loss of the temporal vision. And below that, again, black is air. So we have the sphenoid air sinus. Okay. The blood supply here is a little bit tricky, but I'm going to try and simplify that for you now. Let's just have a quick overview. We said the pituitary is a master endocrine gland. Why? Because it synthesizes and releases many different hormones which go and act on multiple endocrine glands. For example, we have TSH will go act on the thyroid gland. We have ACTH will act on the adrenal cortex. LH, FSH on the gonads, and so on. So the hypothalamus has to very precisely control the pituitary secretion because any misstep can cause so many different problems. The communication between the hypothalamus and the pituitary gland is called the hypothalamic pituitary portal system. Okay. So it goes like this. We have the hypothalamus releasing hormones, which act on the pituitary gland to release hormones, and then it goes and acts on different endocrine organs. All right. For the structure, firstly, we have the arterial supply. The arterial supply, in this case, is the superior hypophyseal artery, which is a branch of the internal carotid artery. Next, we have the primary capillary plexus. This is located in the median eminence. It's part of the hypothalamus. Then we have the long hypophyseal portal veins. This is what connects the primary capillary plexus to the secondary capillary plexus, which is located in the anterior pituitary. So we're moving from the hypothalamus down to the pituitary gland. And it goes like this. We have the internal carotid artery. It gives rise first to the superior hypophyseal artery, okay? This then goes and connects to the primary capillary plexus, which is located in the median eminence as part of the hypothalamus. Then the hormones are carried from the primary plexus to the secondary capillary plexus, which is located in the anterior pituitary through the portal veins, okay? The portal veins are in the infundibulum, and they go and connect the primary plexus to the secondary plexus. And then the hypophyseal veins are what will carry the hormones to circulation to the other endocrine glands and so on. All right, so this is just a quick summary again. We have the hypothalamus will release its regulatory hormones. These can either stimulate or inhibit the pituitary gland. These are the examples. We're going to be discussing them all in detail later on. So these hormones will travel, like we said, through the primary plexus to the portal veins to the secondary capillary plexus in the pituitary gland. And it will either stimulate or inhibit the pituitary gland, okay? And then as a result, let's say it's stimulating the pituitary gland. Now the anterior pituitary will release hormones, okay? These hormones can be TSH, ACTH, growth hormone, LH, and so on. So the anterior pituitary has to do with 6 different hormones. And then, like we said, these hormones will enter the circulation through these hypophyseal veins, where they will go to their target endocrine organs. So this is just everything once again. I just really want to stress this topic. This is the very overwhelming slide, honestly, from Dr. Yaqeen's presentation. We have, for the anterior pituitary circulation, the hypothalamus will release its regulatory hormones, which will go from the superior hypophyseal artery all the way to the primary plexus, which is in the hypothalamus. These hormones will then be carried through the portal veins from the primary plexus to the secondary plexus. Here is where they're going to be stimulating the anterior pituitary. Now, the anterior pituitary is going to synthesize and release its own hormones. Once these hormones are released, they're going to be going from the hypophyseal veins into the circulation and to their target organs. And then once they complete whatever they have to do, it's going to go all the way back to the hypothalamus as a negative feedback to stop the hypothalamus from releasing any more hormones. I hope that that's clear. Okay, so that was all for the anterior pituitary's blood supply. For the posterior pituitary, it's much more simpler. It has a direct blood supply from the inferior hypophyseal artery. That's it. So the inferior hypophyseal artery is also a branch of the internal carotid. It will form its own capillary plexus within the posterior pituitary lobe. And then it will just release the hormones that are stored in axons, and these are produced by the hypothalamus. So we have ADH and we have oxytocin. And then it will just enter the circulation later on via the hypophyseal veins. Okay, just a quick checkpoint. Does anyone have any questions so far, or is everything clear? Okay, I'm hoping everything is clear. All right, great. Moving on. Oops, moving on. Now we're going to be discussing the embryology. For the development of the pituitary, the anterior pituitary and the posterior pituitary are developed from 2 different parts embryologically. The anterior pituitary will come from Rathke's pouch, which is a part of the oral ectoderm. The posterior pituitary will come from neuroectoderm, which develops as a downward extension of the diencephalon. I believe you guys are going to have a more detailed PAL session on embryology, but I'll go through this quickly. So once we have both of these tissues, they're going to fuse, and that's what's going to form the pituitary gland. Here we can see we have the blue is the neuroectoderm, the red is the oral ectoderm. So here we have the neuroectoderm and Rathke's pouch. They're going to begin fusing, okay? And they're going to fuse while the sphenoid bone is developing. You can see it's developing and curving, and now we have the sella turcica as well, and the pituitary gland is then being formed. So posterior pituitary is neuroectoderm, anterior pituitary is the oropharynx or oral ectoderm. Okay, now moving on to histology. The anterior and posterior pituitary both look very different when we look at them histologically. The anterior pituitary is very highly cellular and it has very densely packed cells, and they're arranged in cords. We also have some sinusoidal capillaries here and there. But when you look at it through the microscope, you're going to see that the anterior pituitary appears much darker than the posterior pituitary, which is lighter. It is composed of neural tissue. It is not glandular or highly cellular like the anterior. And it's mainly unmyelinated axons and supporting cells. And the fact that it's unmyelinated axons is what gives it the lighter appearance. So here we can see the pituitary gland. Here's the anterior pituitary. It is glandular, like we said, and it is more eosinophilic, so it's darker in color. The posterior pituitary is mainly unmyelinated axons, which is what makes it less eosinophilic or makes it paler. Okay, so looking closer at the anterior pituitary cells, it is composed of three main cells. We have acidophils, which are red, we have basophils, which are blue, and we have chromophobes, which are pale. So you can see them here. These are the basophils. They're more red or a darker pink. The chromophobes, which are completely pale, and the the basophils, which are blue. I confused them. The chromophobes, which are pale, and the acidophils, which are red or a darker pink. And so these are the cells, the different cells that are going to be producing the hormones. Just keep this in mind. The somatotrophs and the lactotrophs, which produce growth hormone and prolactin, these are acidophils. They're going to stain red on the microscope. And then the rest, corticotrophs, gonadotrophs, thyrotrophs, these are all going to be basophils, and they're going to stain blue. As for the posterior pituitary, we said we have the axons, the unmyelinated axons from the hypothalamic neurons, and we're also going to have something called pituocytes. Pituocytes, they're basically supporting cells. They're glial cells that are just supporting, they're just there. And we have also something very important called Herring bodies. Herring bodies are what are going to store the posterior pituitary hormones, which are ADH and oxytocin. They're going to be stored in Herring bodies. And these are basically just dilated axon terminals. So here we can see it more closely. We have the Herring bodies here. As you can see, they're enlarged, they're bigger. Think of it that they are storing the hormones, so it makes sense that they're bigger. And these smaller cells over here, these are the pituocytes, which we said are the supporting cells. Okay, so now introduction to the hormones. The pituitary hormones are, okay, we have 6 main hormones from the anterior pituitary. We have growth hormone, we have thyroid stimulating hormone, which is TSH, adrenocorticotropic hormone, ACTH, follicle stimulating hormone, FSH, luteinizing hormone, LH, and prolactin. Please keep in mind the abbreviations because this is how I'm going to be referring to them moving forward. These hormones are all controlled by the hypothalamus using the portal circulation, which we just went through now. And I want you to remember that the anterior pituitary hormones are trophic hormones. What this means is that basically they're going to go and stimulate other endocrine glands to release their own hormones. So they're not going to be acting directly. They're going to act on another gland, and they're going to cause that gland to go and release its own hormones. For the posterior pituitary, we have only 2 hormones. It's much simpler. We have ADH or vasopressin, and this is antidiuretic hormone, and we have oxytocin. Unlike the anterior pituitary, these don't have a portal system. They're just directly transported down from the hypothalamus through axons to the posterior pituitary, and these act directly. They don't go cause any other glands to release their own hormones. No, they just go and they act on a non-endocrine tissue, and they just trigger a final effect. They act directly, and anterior pituitary hormones are trophic hormones. All right. So we're going to be going through these again, but they were in Dr. Yaqeen's slides, so I put them briefly. We can have some pathologies with these hormones, of course. Like I said, the anterior pituitary is a master endocrine gland, so it has a lot of things going on, and any misstep can cause a lot of problems. So when talking about growth hormone, we can have two main pathologies. We can have a deficiency in growth hormone or an excess. When we have a deficiency, we will mainly have, again, decreased secretion, obviously. And then in children, this will cause something called dwarfism. So they will just have a very short stature. They will be very short, but they will have normal body proportions. When we have an excess secretion of growth hormone, this can be caused by an adenoma. If this happens before puberty, we're going to have gigantism. And if this happens after puberty, we're going to have acromegaly. Okay. And in this case, we're going to see excess height. They're going to be very tall in gigantism. And in acromegaly, they're going to have coarse features, which, yeah, here's a key takeaway. Decreased growth hormone, dwarfism, increases gigantism or acromegaly. Here we can see the excess. This is acromegaly. We said this happens after puberty when we have an excess of growth hormone. They're going to have very large hands, and you can see they have very coarse facial features. In gigantism, this happens before puberty, and you can see here they are very tall. They have an increased linear growth. Their skeletal system, their skeleton is growing very rapidly. As for ADH or vasopressin, we can have two main disorders as well. We have diabetes insipidus, and we have syndrome of inappropriate ADH secretion. Okay, so in diabetes insipidus, we have very little ADH. And this is going to cause a lot of dilute urine. We're going to have excess urination, thirst, because what's happening here is we're losing water. We're losing water. So we're going to have a lot of urine. We're going to be very thirsty and so on. The kidneys are unable to reabsorb water. Okay, so it's just excreting all of it. We're losing the water. And SIADH, we have an excess of ADH secretion. So we have a lot of ADH. And what's happening here is the kidneys are absorbing too much water, more than they should be. So now we're retaining water. We're also going to have a hyponatremia. So because we're going to have electrolyte imbalances now. And so basically, decrease ADH, we're going to have diabetes insipidus, water loss. Increase will be SIADH, we're going to be retaining water. We're going to have water retention. Okay, with that being said, we're done with the first lecture. Again, I hope everything is clear. If not, please let me know if you have any questions. Okay. Now I just have a few questions for you guys. Oops. Question number 1. We have a 14-year-old boy hit his head on an asphalt road after falling off his skateboard. His radiograph reveals damage to the sella turcica. This is probably due to fracture of which of the following bones? So there's damage in the sella turcica, and this is which bone? Yes. Sorry for the spoilers. Yes, correct. The sphenoid bone. Next question. We have a 53-year-old woman diagnosed with having a pituitary tumor. If the tumor is large enough, she can exhibit which of the following disorders? Amazing. Yes, you're correct. The answer is bitemporal hemianopia, because we said that if a tumor compresses the optic chiasm, which is above the pituitary gland, we'll have here the loss of the temporal vision of the eyes. And the last question is, which of the following cells or parts of the pituitary are derived embryologically from the neuroectoderm? Yes, correct. The herring bodies, because we said this is part of the posterior pituitary. The rest are all part of the anterior pituitary. So this is the only thing that will come from the neuroectoderm. All right, now moving on to the physiology aspect of this lecture. Firstly, the hypothalamus integrates, it's like an integration center, and it controls the function of the pituitary. What happens is that we have many different stimuli, stress or anything else. It can go and send information to the hypothalamus. And now the hypothalamus is going to act on these stimuli, act on these signals, and it's going to regulate the secretion of pituitary hormones. So some of these stimuli can be neural inputs. For example, we can have emotional stress. This is going to activate the HPA axis, which is the hypothalamic pituitary axis. We can, hypothalamic pituitary adrenal axis. We can have physical stress, such as pain or surgery or trauma. We can have things with the limbic system. We can have biological rhythms, circadian rhythms, which is very, very important, the sleep-wake cycle, which we're going to talk about now. And also different seasons can affect reproductive hormones. And finally, we can have different chemical signals, such as circulating hormones having negative feedback on the hypothalamus, different electrolytes, metabolites, glucose, and cytokines. And just a clinical note, if we have very severe stress, then this hypothalamus pituitary axis is going to keep being activated. So even if there's a negative feedback, the severe stress is going to override that negative feedback, and the hypothalamus is going to keep signaling the pituitary to release hormones. Okay, now I told you here that the circadian rhythms and the sleep-wake cycles are very important. Why? Because some hormones do follow a sleep-wake pattern or a cycle, and this is regulated again by the hypothalamus. We have the suprachiasmatic nucleus, the SCN. It is a nucleus that's located in the hypothalamus. And what it does is basically, it is the master circadian clock. So it's what regulates these circadian rhythms. And this coordinates the release of hormones and the sleep-wake patterns throughout the body. So you're going to see that some hormones may be secreted the most in the morning, some may be secreted the most at night. And this is very important for physiological function because we can't have all the hormones constantly being secreted at one time. And if we have circadian rhythm disruption, this can be linked to many pathologies. We can have mood disorders, obesity, diabetes, cancer, and so on. So it is a very important concept. Okay, back to the hypothalamic hypophyseal portal circulation again, hypothalamic pituitary portal circulation. This is what allows the hypothalamus to control the pituitary gland. Okay, so this is very important because, like we said, the pituitary gland is responsible for so many functions. So the hypothalamus really needs to control it tightly. Again, we said the pathway is, just to recap, the hypothalamic neurons will release hormones to the primary capillary plexus, and then the portal veins will carry these hormones to the secondary capillary plexus, which is in the anterior pituitary, and then we're going to have the hormone exchange and the trophic effects of the anterior hormones and so on. And these are the different hypothalamic regulating or releasing hormones that act on the anterior pituitary. I'm going to go through them once because, again, I'm going to be using the abbreviations. TRH is thyrotropin releasing hormones. This acts on TSH. CRH, corticotropin releasing hormone, will release ACTH. GnRH, gonadotropin releasing hormone, will release FSH and LH. And finally, GHRH is growth hormone releasing hormone. Oh, not finally, but we have growth hormone releasing hormone will release GH. And then these last two, somatostatin and dopamine, they are inhibitory. You can see all of these are releasing, but these two are inhibitory. So somatostatin is mainly going to be inhibiting growth hormone, and dopamine is going to be inhibiting prolactin. Okay. All right. Another important concept is negative and positive feedback, because this also basically modulates the whole hypothalamic pituitary axis. So we said the hypothalamus has a releasing hormone. It acts on the pituitary, which will release trophic hormone, which will go and act on a target endocrine gland, which will release its own hormone. Once this target gland makes its own hormone, it will go back and stimulate the hypothalamus to inhibit, to stop releasing hormones, stop the pituitary from releasing hormones. Khalas, there's enough. So it will inhibit the hypothalamus and the pituitary. For example, we have the thyroid axis. We have TRH from the hypothalamus, will go and release TSH from the pituitary, and then it will go and act on the thyroid gland to release thyroid hormones, T3 and T4. Once we have enough T3 and T4 or high levels, it's going to go back to the hypothalamus and it's going to suppress the TRH and the TSH. So no more release of hormones. Here's another example of the negative feedback. We have a stimulus, which will stimulate the hypothalamus to release a hormone, in this case, CRH. And this will act on the pituitary gland to release ACTH. It will then act on the adrenal glands, which releases cortisol. And once we have enough of this cortisol, it's going to go back. It's going to have this negative feedback loop. It's going to stop the hypothalamus and stop the pituitary gland from releasing any more hormones. Now, we also do have positive feedback, but it is much less common. The negative feedback you'll see in basically every cycle, but the positive feedback we will see only in the menstrual cycle. Basically, in the menstrual cycle, what happens is we have a rise of estrogen, which will trigger an LH surge, and this will cause ovulation. Once we have ovulation, then the system will go back to negative feedback. So we don't have positive feedback very often. And again, we will go into this in more detail once we talk about LH and FSH. So here's how the positive feedback mechanism works. We have the hypothalamus releasing the gonadotropin releasing hormones. It acts on the pituitary to release FSH and LH, which acts on the ovaries. We have follicle growth. These follicles, as they're growing, they're releasing estrogen. And this estrogen goes back to the anterior pituitary and the hypothalamus. And this is going to keep happening until we have that LH surge and that ovulation. And then we're going to be moving to negative feedback again. So positive feedback, not as common as negative feedback. All right, now for the main bulk, we're going to be discussing the anterior pituitary hormones. Generally, we have all of these different hormones. The most commonly produced one is growth hormone. It is a somatotroph. Remember, we said that somatotroph are acidophils, so they stain red when we look at it through the microscope. And it is 30 to 40% of the anterior pituitary secretions. We have ACTH and MSH, which we're going to be discussing. These are corticotrophs, 20%, so they're the second most secreted. Then we have the TSH, thyrotropes, gonadotrophs, 3 to 5%, all of them, and prolactin, which are the lactotrophs, or also acidophils, 3 to 5%. These are all basophils. Okay, so just before we go into each of the hormones individually, let's look at what all of these hormones have in common. Firstly, they're all peptides, or they're protein hormones. And this is important to note because if someone needs to, for example, take more hormones, if someone needs more growth hormone, we cannot give this to them orally. They cannot take a pill of growth hormone because since they're peptides, then they're not going to be able mainly to stand the stomach acids. So they're not going to last, okay? So that's why normally when we give someone more of these pituitary hormones, it is done through injection, okay? They cannot cross cell membranes because they're water soluble. They act via membrane receptors, mainly G protein coupled receptors. They're all going to be stored in secretory granules and then released via exocytosis. And all of them have very short half-lives. So within minutes to hours, and then خلاص, they're gone, okay? Yeah, here, like I said, growth hormone, we need to do it through injections because we cannot take it orally. Now, let's begin talking about growth hormone. Just as a quick overview, growth hormone, they're secreted by somatotrophs. Again, we said that the majority or the most secreted hormone is growth hormone. It is a peptide, like we said, consists of 191 amino acids. It is stored in secretory granules released by exocytosis. So you're just going to see this across all the different hormones, basically. For its transport, 50% is going to be bound to growth hormone binding protein, or GHBP, in circulation. So in circulation, 50% of growth hormone is bound to this binding protein. And this basically just extends its half-life. Because remember, we said here that a lot of these hormones have very short half-lives. So when it is bound to this binding protein, it's going to have a longer half-life. Something very important as well that you guys are going to keep seeing as I continue to explain is that growth hormone is secreted in a pulsatile manner. That means that it is not constantly being secreted. So like 6 to 8 times a day, you're going to have a secretion of growth hormone. And again, back to the circadian rhythm, to the sleep-wake cycle, you're going to see that the most growth hormone secretions or the largest pulses happen during deep sleep. So the secretion is pulsatile, not constant, and the most time that we have these secretions is going to be during deep sleep. If we have continuous exposure to growth hormone, then the receptor is going to downregulate. We cannot have continuous exposure because the receptor basically cannot handle it, okay? Here are some of the things that stimulate growth hormone. The main thing is the growth hormone releasing hormone from the hypothalamus. This is going to come and this is going to stimulate the release of growth hormone. We can also have ghrelin, which is the hunger hormone in the stomach, deep sleep, exercise, stress, so on. The main inhibitor of growth hormone, like we said before, is somatostatin, which comes from the hypothalamus. This is the main thing that's going to be inhibiting growth hormone. Also, we're going to be having IGF-1, insulin growth factor 1, which will have a negative feedback and inhibit growth hormone. Free fatty acids, obesity, aging, so on. Okay, another thing important to note, we said that growth hormone is pulsatile, right? It's not constantly being secreted. It's being secreted in pulses. So it is very difficult for us to measure the levels of growth hormone because it's not constant. That's why we use IGF-1, insulin growth factor 1, to measure the levels of growth hormone because it's far more stable. So it's easier to measure IGF than it is to measure growth hormone. Okay, so growth hormone has direct effects and it has indirect effects. The indirect effects are via IGF-1. For the direct effects, we can have things as a decrease in insulin sensitivity. We can have increased lipolysis, breakdown of fats, increased production of glucose, and retention of sodium. Growth hormone acts as a counter-regulatory hormone. What this means is that basically it's going to, whatever insulin does, it's going to oppose that. It opposes the effects of insulin, okay? And this also happens with cortisol, glucagon, and epinephrine. For the indirect growth hormone effects, we said this is mediated by IGF-1, which is produced by the liver, okay? And this is going to have a role in protein synthesis, the growth of the bone growth, the epiphyseal plates, right? Because with growth hormone, you're growing. This is the main thing that you think of when you think of growth hormone. We're going to have cell proliferation, anabolic effects. Okay, so now let's talk about the growth hormone IGF axis. So how the growth hormone acts with the IGF, okay? Firstly, we have the hypothalamus, which is going to release growth hormone releasing hormone, and this is going to stimulate the release of growth hormone. And it's also going to be releasing somatostatin, which inhibits the release of growth hormone, okay, at the same time. Then we'll have mainly the GHRH acting on the anterior pituitary to release growth hormone. This growth hormone will then go to the liver, and here it will produce and release insulin growth factor 1, okay? This insulin growth factor is responsible for many of the growth effects that growth hormone has on tissues. So it's very important working with growth hormone to have the IGF-1. And at the same time, it's going to have a negative feedback. So once we have enough of this IGF-1, it's going to go back to the hypothalamus and back to the anterior pituitary, and it's going to stop them from releasing their hormones. Yeah, so here's the feedback. We said IGF-1 will inhibit the release of growth hormone and the release of GHRH, and somatostatin will inhibit the release of growth hormone. And this is just generally the axis. We have the hypothalamus releasing somatostatin, GHRH. They act on the anterior pituitary to release growth hormone, which will go to the liver, produce IGF-1, and then this is going to go back and it will have a negative feedback on the anterior pituitary and the hypothalamus to stop releasing their hormones. Somatostatin will also inhibit the release of growth hormone. And like we said, some of the stimuli are stress, hypoglycemia, ghrelin, hunger hormone, so on. So what are some disorders of the growth hormone? We went through these briefly before. We said gigantism. This is when we have excess growth hormone pre-puberty, so before the epiphyseal plates close. Mainly caused by a pituitary adenoma. And what we're going to have here, we said we're going to have very tall stature. These patients are going to be very tall. They're going to have excessive linear growth. Their bodies are going to be proportionate, and they're also going to have organomegaly, so they're going to have enlargement of their organs. For acromegaly, this is when we have excess growth hormone after the epiphyseal plates closed, okay? So this is after puberty. Here, they're not going to have the increase in height you see in gigantism, but they're going to have enlarged hands and feet. They're going to have coarse facial features, enlargement of the jaw, skin thickening, so on. Complications could be diabetes, hypertension, cardiomyopathy, so on. And we also have dwarfism, which is when we have a deficiency in growth hormone. This can also be caused by tumors, by genetic defects, trauma, so on. Here, the patients are going to have very short stature. They're going to be very short, as you can see here. Okay, they're going to have a proportionate body, delayed puberty, increase in body fat as well. And you normally treat this with growth hormone injections, though I don't think you need to know all of that. All right, that's it for growth hormone. Now moving on to adrenocorticotropic hormone, ACTH. As a quick overview, ACTH is going to be secreted by corticotroph cells from the anterior pituitary. It is also a peptide hormone, consists of 39 amino acids, and something very important to note, because I've seen this in questions, and also it's just a topic that keeps being brought up. ACTH is derived by POMC, okay, which is pro-opiomelanocortin. This is just basically a precursor peptide, okay? And this is what is going to be cleaved, and it will give us ACTH along with some other hormones, which we'll get into. What stimulates ACTH? We have CRH from the hypothalamus, stress, hypoglycemia, and again, circadian rhythm. And the main inhibitor of ACTH is cortisol. It's a negative feedback because we're going to be producing cortisol, and it's going to go back to the hypothalamus and the pituitary to inhibit ACTH again. And the primary function of ACTH is to basically stimulate the adrenal cortex to release cortisol. That's the main effect. We're releasing cortisol. And this is from the zona fasciculata, okay, of the adrenal cortex. And we also have the release of some adrenal androgen from zona reticularis and aldosterone. But the most important one is cortisol, okay? This is the main effect of ACTH. All right, back again to the circadian pattern. ACTH is also released in pulses, okay? It follows a circadian rhythm. And unlike the growth hormone, the ACTH will have the highest levels in the early morning, okay? So not at night in deep sleep like growth hormone, no. ACTH will have the highest levels, the strongest pulses early in the morning, and the lowest levels will be at midnight. And this is generally just how it goes. This is the hypothalamic pituitary adrenal axis. We're going to have some sort of stress acting on the hypothalamus, okay? Hypothalamus will then release CRH, which is its regulatory hormone. And this is going to go and act on the pituitary to release ACTH, which acts on the adrenal cortex to release cortisol, okay? Keep in mind also that if we have severe levels of stress, then again, this is going to override the negative feedback. So the negative feedback no longer works. Even if we have so much cortisol, it's going to go and try and tell the hypothalamus to stop releasing, but there's so much stress that we're just going to have so much cortisol, okay? And this is how it looks like. This is the axis. We have the hypothalamus, okay? We have the stress, the stimuli, acting on the hypothalamus to release CRH. CRH acts on the anterior pituitary to release ACTH. ACTH will then act on the adrenal gland to release cortisol. Cortisol will go and do whatever effect that it has to do, and then it will go back up as a negative feedback to the anterior pituitary and the hypothalamus, and it's going to be inhibiting the release of any more hormones. Okay, remember we said that ACTH is derived by POMC, right? POMC, we said this is the precursor peptide. When it is cleaved, it produces several other peptides. The main one we said ACTH, but it also releases something called melanocyte stimulating hormone, MSH, which has to do with skin pigmentation, okay? There's also things like beta endorphins for pain modulation, beta lipotropins for fat metabolism, but the main ones we're looking at here is ACTH, which produces cortisol, and MSH, which has to do with skin pigmentation. Why is this important? Because let's say we have some sort of pathology that leads us to have very high ACTH, okay? Since ACTH and MSH both come from POMC when it is cleaved, when we have high ACTH, we're going to have high MSH. So we're going to have hyperpigmentation. And we can see this when we have some sort of diseases that are related to ACTH, okay? So if we have an increase in ACTH, we're also going to be seeing hyperpigmentation because of the increase in the melanocyte stimulating hormone, the MSH. And we can see this in diseases such as primary adrenal insufficiency, which is Addison's disease, and ectopic ACTH production. So we said MSH stimulates melanocytes, so we're going to have increased skin pigmentation. This helps us differentiate between primary adrenal insufficiency and secondary adrenal insufficiency. Why? Because we see it here in Addison's disease, because we're going to have high ACTH and high MSH. So as a result, we're going to have hyperpigmentation. So here we have a problem that's going to result in high ACTH. But in secondary adrenal insufficiency, this is more of a pituitary problem. So we have low ACTH. We're not being able to produce ACTH. As a result, we're not going to have high MSH. So there's not going to be hyperpigmentation. So this whole relation, the whole point of this is that you're able to differentiate between these two, and it helps you identify if we have some sort of problem related to ACTH. Okay, so what are some of the clinical disorders that have to do with the hypothalamic pituitary adrenal axis or just ACTH? Firstly, we have Cushing syndrome. This is when we have an increase in cortisol. We have so much cortisol in Cushing syndromes, okay? Think of it as, I don't know, C, Cushing, C, cortisol, a lot of it. This can be caused by things such as tumors, adenomas, but the most important cause is exogenous glucocorticoids, when someone's taking steroids. This is the most common cause of Cushing syndrome. In this syndrome, patients will present with moon face, central obesity, which is basically they're going to have a lot of fat near the stomach area, very visibly. They're also going to have buffalo hump, which is when fat accumulates at the base of their neck and the top of their back. Muscle weakness, hyperglycemia. The other important clinical disorder is Addison's disease, which we talked about briefly now. This is when we have adrenal insufficiency. So it's a problem with the adrenal glands, okay? The adrenal glands are unable to produce cortisol. We keep having ACTH is okay, the pituitary gland is okay, so we still have ACTH being made and produced, okay? So we're going to have very high ACTH because it's acting on the adrenal glands, but the adrenal glands are unable to produce cortisol. So we're going to have low cortisol, but high ACTH. And remember, we said when we have high ACTH, we have high MSH. So we're going to have hyperpigmentation and other symptoms like fatigue and hypotension. And here's just a side-by-side of the two. And Cushing syndrome, here you can't see the moon face, but they have moon face. They have here the buffalo hump at the top of their back, bottom of their neck. We have here the central obesity and muscle weakness because we have muscle atrophy and so on. For the Addison's disease, we're going to see hyperpigmentation of the skin, right? This is just the most important thing that's, I guess, you can tell because you have high ACTH, high MSH, low blood pressure, weakness, weight loss, so on. All right. Again, we're done with the second lecture now. So if you guys have any questions, please let me know, or is everything okay so far? All right. Wonderful. Okay. Oops. Okay. Now we're going to move on to thyroid stimulating hormone, or TSH. As a quick overview, we have TSH. It's going to be produced by the thyrotroph cells in the anterior pituitary, okay? Thyrotroph. Here, unlike the others, it's not just a peptide, it's a glycoprotein hormone, and it has two subunits, okay? We have an alpha subunit and a beta subunit. The alpha subunit is common to multiple different hormones, TSH, FSH, LH. These all share the same alpha subunit. What differentiates them is the beta subunit. The beta subunit is what's going to be determining the specific activity of each hormone. So the beta subunit is basically what's going to determine what the TSH is going to do, what FSH is going to do, and so on. So the beta subunit is what differentiates these four different hormones. Again, they're going to be stored in secretory granules. they will be released in a pulsatile pattern. And in this case, the peak of TSH is going to be at night, okay? For its regulation, we have various stimulators. The primary stimulus, of course, is going to be TRH from the hypothalamus. We're also going to have exposure to cold, acute stress. These all stimulate the release of TSH. And things that inhibit TSH, firstly, we have T3 and T4. These are the thyroid hormones, and it's going to inhibit TSH as a negative feedback. This is the main inhibitor of TSH, the negative feedback of the thyroid hormones. We also have somatostatin, dopamine, steroids, but this is the most important one. The primary function is that we want the TSH to go and stimulate the thyroid gland, firstly, to take up iodine, okay? We want it to take up iodine. We want it to synthesize thyroglobulin, which is like a precursor and storage form of thyroid hormones. And I believe the most important thing is that we wanted to promote the production and release of the thyroid hormones, which are T3 and T4. And also, it just has the effect of maintaining the gland size of the thyroid gland and its function as well. When we believe that there is a thyroid problem and we want to go and check for it, the most sensitive indicator is going to be TSH. So the first test you're going to order when you suspect a thyroid problem is going to be TSH, because this is the first thing that's going to tell you, okay, there's a problem with the thyroid. The reason why we check for TSH and not the thyroid hormones, because you said TSH comes from the pituitary, while T4, T3, these are the thyroid hormones. The reason why we check the TSH hormone and not the T3 and T4, it's because we will have a rise in the thyroid stimulating hormone. We will have an excess of it before T3 and T4 have the chance to fall or for us to see any change in the thyroid hormones. That is why we always check for TSH first when we suspect a thyroid problem. Okay, now for the hypothalamus pituitary thyroid axis, we're going to have the hypothalamus secreting the thyrotropin releasing hormone TRH. This will act on the anterior pituitary to release TSH. The TSH will then go and act on the thyroid gland to produce the thyroid hormones, which are T4 and T3. Mainly, we're going to be having T4. It is 90% of the thyroid hormones being produced. And we're also going to have 10% of T3. And then this will go and act on its target tissues to perform their function. For the negative feedback, although there is less T3 being produced, T3 is the primary inhibitor with the negative feedback, right? It is way more potent than T4. We have T3 going back and inhibiting these hormones. That is why we also have T4 being converted to T3 in the pituitary by certain enzymes. This will allow the pituitary to then sense the circulating thyroid hormone levels. So T4 is converted to T3 because then the pituitary can sense the T3 and the negative feedback can take place and the anterior pituitary and hypothalamus can stop releasing hormones. Again, here's the HPT axis. We have the hypothalamus being stimulated, okay? It goes and it acts on it releases TRH, which acts on the anterior pituitary, which releases TSH. The TSH acts on the thyroid gland to release the thyroid hormones, T4, T3. It does its effects, and then the thyroid hormones, mainly T3, will go back and do the negative feedback on the pituitary and hypothalamus, inhibiting the release of any more hormones. Okay, so the functions of the thyroid hormones. It has the thyroid hormones, T3 and T4, they have major physiological effects. Okay, they have many different effects. Firstly, it has to do with the BMR, basal metabolic rate, increase of oxygen consumption, heat production. It helps maintain the body temperature. It is very important for CNS development, so the brain development in fetals and neonates. It has to do with the cardiovascular system as well. It increases heart rate and contractility. Also metabolism, glucose utilization, lipid metabolism, protein turnover. I'm not sure how important this is, honestly, but when you cover the thyroid, you'll learn more about this. Okay, for thyroid disorders, typically when we think of thyroid disorders, there's two main things that come to mind. we have hypothyroidism and hyperthyroidism. Firstly, in hypothyroidism, we think, we're thinking hypo, so less thyroid. So we have less of the thyroid hormones, right? So we have less of T3 and T4. But we're going to have an increase of TSH because we have the TSH, we have the thyroid stimulating hormone. It's just not being able to produce the T3 and T4. Okay. Common causes for this. Worldwide, the most common cause of hypothyroidism is iodine deficiency. But in developed countries, we have Hashimoto thyroiditis, which is the most common. It can also be other things like after surgery, radiation, drugs, so on. And again, when we think of hypothyroidism, hypo, so less. So all the symptoms are going to point towards slowing down. So less, slowing down, so on. Oh. Radiation from chemo, it can be from, yes, radiation can be from chemotherapy. It can be different type of radiation. I mean, I think here they just spoke about it generally, but you don't really, it is not very relevant to you now as first years. Okay, so the symptoms of hypothyroidism is going to be like slowing down. We're going to be seeing things like fatigue, cold intolerance, weight gain, okay? Keep this in mind, weight gain with hypothyroidism because it helps you differentiate between the two. Dry skin, constipation, cognitive slowing. So all of these symptoms just make you have the impression that things are slowing down, okay? Treatment, you just give them synthetic thyroid hormone, synthetic T4. So this is how hypothyroidism will typically present. You'll see hair loss, they have cold intolerance, bradycardia, so they have slower heart rates as well. You see everything is slowing down. They have weight gain, they have fatigue. So these are just generally the symptoms of hypothyroidism. For hyperthyroidism, okay, here we're going to have a lot of the thyroid hormones, okay? We're going to have so much T3 and T4, but we're going to have a decrease in TSH. And the most common cause of hyperthyroidism is Graves' disease. What Graves' disease do is it stimulates TSH receptors. And then TSH receptors are not working. We're not being able to, it stimulates the TSH receptors, okay? So we have a decrease of TSH. We can also have adenomas, thyroiditis, excess iodine, but the most common cause of hyperthyroidism is Graves' disease. And unlike, it is the complete opposite of hypothyroidism. So in hypothyroidism, everything was slowing down. In hyperthyroidism, everything is speeding up. So we had cold intolerance in hypothyroidism. Here we have heat intolerance. We had weight gain. Here we have weight loss. There we had bradycardia. Here we have tachycardia. So you see all the symptoms are the complete opposite. Here everything is speeding up. So yeah, tremors, anxiety, and we have exophthalmos, which is a common symptom of Graves' disease. So you will see it in hyperthyroidism since it can be caused by Graves' disease. Treatment for this, we want to reduce the thyroid, not give any more. So we do anti-thyroid drugs. We can even destroy the tissue, the thyroid tissue, the radioactive iodine, and we can just remove the thyroid gland completely. And this is how hyperthyroidism will typically present. You'll see the patient is very sensitive to heat. They're losing a lot of weight. They're sweating. They're hungry. They're anxious. And yeah, that's basically it. Okay. Now we're going to be discussing the gonadotropins, which are FSH and LH. Okay, FSH is follicle stimulating hormone. LH is luteinizing hormone. These are both going to be produced by gonadotroph cells in the anterior pituitary. Like the TSH, these are also glycoprotein hormones. They're going to have the same alpha subunit as TSH and also HCG, human chorionic gonadotropin. But again, the beta subunit is what determines the specificity, yeah, of each hormone. So the beta subunit is basically going to determine what LH does, what FSH does. Okay, we said here in the alpha subunit, it's identical to TSH and HCG. Why is it important that it's similar to HCG? Because sometimes, since they have a shared structure, FSH, LH, and HCG, they have the same alpha subunit, this can explain why sometimes we're going to have the HCG stimulating the thyroid during pregnancy when it's not supposed to be doing that. But since they have the same alpha subunit, so they have a shared structure, HCG can sometimes go and stimulate the thyroid gland during pregnancy, okay? All right. For its regulation, FSH and LH are both going to be stimulated by gonadotropin releasing hormone, GnRH, by the hypothalamus. Again, these hormones are going to be released in pulses. And if we have so these hormones are going to be released in pulses, and the GnRH is going to be released in pulses, okay? But if we have a continuous release of GnRH, okay, by the hypothalamus, not FSH and LH, keep in mind, if we have a continuous release of the gonadotropin releasing hormone, then we're going to be having a decrease in FSH and LH. Why? Because if the receptor is constantly being stimulated, then it's going to be downregulated and it's not going to be able to produce the FSH and the LH anymore. The clinical, and this concept here can be used clinically. So sometimes we can use these GnRH agonists. We don't want FSH and LH. So we're using these GnRH agonists to continuously secrete GnRH because we want to suppress gonadotropins. And we can use this clinically in like prostate cancer, endometriosis, early puberty, basically to slow down the effects or inhibit the effects of FSH and LH. Okay, so here's the functions for both females and males. In females, we're going to see that the FSH is going to be developing follicles, okay? And at the same time, it's also going to be producing estrogen. For LH, in females, it's going to be causing ovulation to happen. And it's also has a role in the formation of the corpus luteum. For males, FSH stimulates Sertoli cells, okay? FSH Sertoli cells, you can make that relation. And at the same time, in males, it also supports spermatogenesis. For LH, it stimulates Leydig cells. So LH, Leydig cells, and it has to do with testosterone production. So just so you can remember, FSH has to do with follicle development in females, and it stimulates Sertoli cells in males. And LH lets ovulation happen in females, and it stimulates the Leydig cells in males. Okay, so for its regulation, for the regulation in females, let's discuss the menstrual cycle. Again, you will be taking this in more details, but I'm going to go over it for the sake of you understanding these hormones. Firstly, the first part of the menstrual cycle, we have the follicular phase, which occurs from day 1 up until day 14. Here, we have the development of the follicles. We said follicular development happens by FSH. So now we have FSH acting, and it's stimulating the development of follicles. These follicles, as they're developing, they're producing estrogen, okay? And this estrogen, as it's being produced, it's going to go and have a negative feedback on GnRH and FSH. So it's going to inhibit the release of these hormones, okay? Next, we have ovulation. Ovulation happening at day 14. Here, we have now reached a high level of estrogen, and we're going to have a positive feedback. Remember how we said we have the positive feedback rarely, and it occurs during the menstrual cycle. So now we're going to be having the positive feedback. This positive feedback, okay, this high estrogen is going to trigger something called an LH surge. So we're going to suddenly have so much LH being produced. We're going to have just a rapid rise in LH, okay? And then this LH surge is basically going to cause the follicle that was developed through the stimulation of FSH. It's going to cause this follicle to rupture. And once this follicle ruptures, this is ovulation, okay? Ovulation has now happened. And then the last phase we have is the luteal phase, okay? This occurs from days 14 to 28. Here we have the formation of the corpus luteum. Remember, this also is a function of LH. And also we're going to have the production of progesterone, okay? And a little bit of estrogen, but mainly progesterone. What progesterone does is that it prepares the uterus for implantation. So it basically is preparing the uterus for pregnancy. It's preparing the uterus for implantation. And also, it's going to have a negative feedback on GnRH and LH. So here, the estrogen had a negative feedback on mainly FSH, but here we're having a negative feedback now on LH. So we said the progesterone was preparing the uterus for implantation, right? But if there is no implantation, if there is no pregnancy, then this corpus luteum is going to degenerate, and progesterone will begin to fall, and menstruation will occur. So here's just a table showing you everything. Basically, in the beginning, we're going to have a little rise in estrogen. Here we have FSH working on the follicles, developing the follicles. And then the estrogen is going to rise. Suddenly we have a high level of estrogen now, okay? And this high level of estrogen is going to cause LH to have its surge. We're going to have a rapid release of LH. So now here you can see just it's skyrocketed basically. We have this LH surge, and this is when ovulation happens. And then we said that at this part over here, we're going to have the rupture of the follicle, okay? This is ovulation. And then LH will begin to fall, and we'll also be having the negative feedback. And we'll see that progesterone starts to rise, and the corpus luteum is being formed here. The progesterone is rising, it's preparing the uterus for implantation. But if there's no implantation, then the progesterone will fall, the corpus luteum will degenerate, and we have menstruation towards the end of the cycle over here as everything's falling. Okay, that was for the female hormone regulation. For the males, we have the HPG axis, okay? Hypothalamic pituitary gonadal axis. We have the hypothalamus will release the GnRH in pulses, okay? Every 60 to 90 minutes, we're going to have a pulse of gonadotropin releasing hormone from the hypothalamus. This GnRH goes and acts on the anterior pituitary. And the anterior pituitary releases FSH and LH. We said FSH is going to act on Sertoli cells. What Sertoli cells do is they have a role in spermatogenesis. What LH does is it acts on Leydig cells, and it aids in the release of testosterone, okay? What testosterone's main functions is the male have their secondary sex characteristics as a result of testosterone, supports spermatogenesis, it has to do with muscle mass, bone density, stimulates erythropoiesis, and so on. Again, once you guys reach repro, you will be discussing this in so much more detail. That's why I'm being a bit, I'm not giving you that much detail, just an introduction. For the negative feedback, we have testosterone going back inhibiting GnRH and LH, okay? So testosterone, since it's being produced by LH, it's going to go back and have a negative feedback on LH. And then we have inhibin, which is something from Sertoli cells, okay? This is what's going to go back and inhibit FSH. So we can see this all here, okay? We have the hypothalamus, it's releasing GnRH. Okay, this GnRH acts on the anterior pituitary to release LH and FSH. LH will go and act on the Leydig cells, and it produces testosterone. Okay, this testosterone will go back and it will have a negative feedback on the pituitary and hypothalamus. They'll stop releasing LH and GnRH. For the FSH, it will go act on Sertoli cells, and this will aid in spermatogenesis, okay? And the Sertoli cells will also release something called inhibin B. Inhibin B is what will go back to the pituitary gland, and it will have the negative feedback and inhibit the release of any more FSH. Does this mean high testosterone can cause male infertility? Honestly, I'm not completely sure. I don't want to give you a wrong answer. This will be covered in repro and in more detail, inshallah. If you want, I do have my details at the start and end of the presentation. You can reach out to me and I'll get you the answer, inshallah, properly. Okay. For the clinical correlations, we have just generally different things that can go wrong with the gonadotropins. We have primary hypogonadism, okay? In this case, we have hypogonadism, so we have less testosterone, we have high LH and high FSH. This is basically just testicular failure, okay? We have very little testosterone. We have secondary hypogonadism. Here we have decrease in testosterone, but we also have a decrease in LH and FSH. So here we have a failure of the pituitary. Here you see there's still increase because this is a failure and this is testicular failure. So the pituitary is still working fine. But here the pituitary is also failing. So everything is decreased. Finally, if we have someone that's abusing steroids, if they're abusing anabolic steroids, for example, they're taking exogenous testosterone, okay, they're taking testosterone for whatever reason, this is going to go back as a negative feedback, okay, and this is going to suppress GnRH, LH, and FSH, and this is going to cause infertility and testicular atrophy. For Zaid, you asked the question about high testosterone. I'm not sure about when testosterone is being produced by the body. But here, if you do have exogenous testosterone, it will continue to suppress the different hormones here from the hypothalamus and the pituitary. So this will lead to infertility. I hope that partially answers your question, but I will still get back to you, inshallah. No problem. Okay. Okay, and for the last, I believe, anterior pituitary hormone, we have prolactin. Okay, so prolactin is going to be produced by lactotroph cells by the anterior pituitary. Here it is just one chain polypeptide with 199 amino acids. Now, what makes prolactin unique is the fact that this is the only anterior pituitary hormone that is primarily being inhibited. So everything else is being stimulated, right? All the other hormones we've discussed are being stimulated, but prolactin is constantly, it's tonically being suppressed, and it is being suppressed and inhibited by dopamine. So dopamine is a prolactin inhibitory factor. It is constantly inhibiting prolactin, okay? If we remove dopamine's inhibition on prolactin, then we will have an increase in prolactin. But other than that, prolactin is tonically, it is constantly being inhibited. For its regulation, the inhibitor we said, what decreases prolactin is dopamine. Dopamine is the primary inhibitor of prolactin. It tonically inhibits prolactin. This is a very important concept for you guys to grasp because this is the only hormone that is under inhibitory control, right? For the stimulators, we have TRH, okay, TRH coming from the hypothalamus. This is going to stimulate prolactin, estrogen, stress, sleep, and of course the infant suckling reflex during breastfeeding. This is the most, I believe this is the most potent stimulator, that when the infants are suckling on the nipples during breastfeeding, this is what causes an increase in prolactin, right? Okay, so what does prolactin do? The most important thing is lactation, right? So we have prolactin stimulating the production of milk in mammary glands. And it works with oxytocin for milk ejection. But don't get confused. Oxytocin is not producing milk. It's just helping with the ejection. Prolactin is what produces the milk in the mammary glands, okay? It also has to do with reproductive inhibition. So if we have high levels of prolactin, this is going to go back as negative feedback. It's going to inhibit GnRH, and it's going to decrease LH and FSH. So prolactin, although this is gonadotropin, prolactin will inhibit GnRH, okay? It will inhibit LH and FSH. It can also lead, because of this, it can lead to the absence of menstruation, okay? It will lead to amenorrhea because we don't have LH, we don't have FSH, we can't have menstruation happening, we can't have ovulation, all the phases are now disrupted because we don't have LH and FSH. So this will lead to amenorrhea and it will lead to infertility. And some other effects that prolactin has is generally it influences maternal behavior, and also it has to do with immune system modulation, okay? But the most important thing definitely will be lactation, okay? The production of milk in mammary glands. Some of the pathologies, well, not some of, the pathology we're going to be discussing with prolactin today is hyperprolactinemia, okay? This is when we have very high levels of prolactin, and this is abnormal, of course. Some causes of this can be a pituitary adenoma, prolactinoma, so it's just an adenoma that's going to be producing prolactin so much. We can have some dopamine blocking drugs, antipsychotics, primary hypothyroidism. So if we have an increase in TRH, this can also lead to us having high levels of prolactin, pituitary stalk compression. Okay, so what are the different symptoms of this? Firstly, in women, we will have galactorrhea, okay? This is when they're going to have milky discharge from the nipples, even if they are not breastfeeding, okay? Which is abnormal, of course. Amenorrhea, infertility. For men, they'll have decreased libido, okay? They're going to have erectile dysfunction and gynecomastia. And for both of them, some general symptoms will be headaches and visual field defects. For the treatment, this is not very important, but we'll have dopamine agonists. It will shrink tumors, reduce prolactin. But just remember, hyperprolactinemia, we have abnormal high levels of prolactin. Mainly it will be because of a prolactinoma, so an adenoma. And I think you'll most commonly come across this with women. Okay, we're done with the second lecture now. Oh, not the second lecture, sorry. We're done with the anterior pituitary hormones. We'll move on to the posterior pituitary hormones. Any questions? Or is everything okay so far? Okay, okay, great. Us. Now we will move on. Let's just keep doing that. I have just a few questions. We said, which of the following substances is going to be derived from POMC? Do we need to know why prolactin inhibits? Okay, I'll get back to this question. Let me just answer this. Do we need to know why prolactin inhibits GnRH? When I was going through the slides of your doctor, okay, he did not mention how prolactin inhibits, where is it? He did not mention how prolactin inhibits GnRH. I went through the whole presentation. He just said that if you have high prolactin levels, then it can inhibit GnRH, which will in turn, it will decrease LH and FSH, okay? That's all that was mentioned. So I really doubt that you need to know it in details because it was not written in details whatsoever. This is all that was said. Okay, and yes, you're all correct. ACTH is derived from POMC. Good job. Now, we have a 46-year-old woman, has blah, 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 hyperglycemia, obesity, muscle wasting, increased circulating levels of ACTH. What is the most likely cause of her symptoms? So we have an increase in ACTH. We see this in which disorder? Yes, good job. It is Addison's disease, primary adrenocortical insufficiency. And can you guys, oh, I got confused. Sorry. It is not going to be A because in A we have adrenocortical insufficiency. It's not Addison's disease. It's also going to be in Cush. Oh, okay, wait. Sorry. I think I have this question written down wrong. I believe it is Addison's, but the question bank I got it from confused it a bit because here it says overproduction of ACTH. So technically both are correct. Anyways, I will fix this in the presentation, but you guys are correct. Well, they didn't mention the hyperpigmentation, but you can't always expect to see hyperpigmentation, honestly. And we said that the hyperpigmentation, yes, we don't see it in Cushing's, but here it's saying that we have an overproduction of ACTH. The question is a bit messed up. I didn't realize before. I will fix it later on. But yeah, both of these, you're going to have an increase of ACTH because here it's saying overproduction. Okay. And now for the last part, we're going to be looking at the posterior pituitary hormones. Okay. Just as a quick overview before we get into the individual hormones, the key difference between the posterior pituitary and the anterior pituitary is that the anterior pituitary synthesizes hormone. The posterior pituitary does not synthesize any hormones. All it does is it stores hormones that are made by the hypothalamus and then it releases them. That is the only thing that the posterior pituitary does. So hormones will be synthesized in the hypothalamus and then they'll be transported to the posterior pituitary gland. And then the posterior pituitary gland will just store them and release them. We have two main hypothalamic nuclei, which work with each of the posterior pituitary hormones. We have supraoptic nucleus, which mainly regulates ADH or vasopressin, and we have the paraventricular nucleus, which mainly regulates oxytocin. Although both nuclei work on both hormones, SON mainly has to do with ADH and PVN mainly has to do with oxytocin, okay? And some of the key features is that all of these hormones will be transported via axons of magnocellular neurons. This isn't that important. They will be stored in Herring bodies. Remember, we said Herring bodies, these are the enlarged nerve endings. These bodies are what will store the oxytocin and the ADH. the hormones are directly released into the bloodstream. They don't go act on an endocrine organ. No, they just go and directly do the effect that they need to do. And again, there's no portal system. Okay, so how are these hormones synthesized? For the posterior pituitary, these hormones, ADH and oxytocin, they follow this pathway. Okay, we have a pre-pro hormone, which becomes a prohormone, which becomes an active hormone. Initially, we're going to have gene transcription. So in the nuclei of hypothalamic neurons, we're going to have DNA being transcribed into mRNA. After that, we're going to have the formation of the pre-pro hormone, okay? So through translation in the rough endoplasmic reticulum, we're going to have the formation of the pre-pro hormone. The pre-pro hormone is composed of three things. We have a signaling peptide, okay? We have the hormone, and we have neurophysin. Neurophysin is just a carrier protein. It's what's going to be carrying the hormone, okay? The next step is we're going to remove the signal peptide. So the pre-pro hormone has these three things. Once you remove the signal peptide and it becomes just the hormone and the carrier protein, the neurophysin, it's going to become the prohormone. So the prohormone is the hormone and the neurophysin, okay? After that, the prohormone will be packaged into a secretory vesicle, okay? It's going to be packaged into the secretory vesicle, which will travel down along an axon, okay? And it will be cleaved. Once it travels down the axon, it reaches the posterior pituitary, it's going to be cleaved. The active hormone and the neurophysin are no longer going to be together. The neurophysin will leave the active hormone. So, like we said, remember, we said, oops. We said here we have the pre-pro hormone. This happens through the translation. Then we remove the signaling peptide. This becomes the prohormone. And then as soon as we remove this neurophysin, then we'll just have the active hormone alone. But this active hormone, if we don't need it right now, then it's just going to be stored in the herring bodies until there's a signal basically saying that we need this hormone, okay? So up until the hormones are needed, they're going to be stored in these herring bodies. And just a quick note, these neurophysins, they're carrier proteins, all right? They just carry the hormones during transport, and they basically just stabilize them. We have two types, neurophysin 1, which is the one that binds oxytocin, and we have neurophysin 2, which has to do with ADH. So just know 1 oxytocin, 2 ADH. That's it. All right, for the first of the two posterior hormones, firstly, we have antidiuretic hormone, which is ADH or vasopressin. The primary role, okay, the main thing that ADH does is that it maintains the balance of water and plasma osmolarity. The target of ADH primarily is going to be the collecting ducts of the kidney, okay, the collecting duct cells of the kidney. Over there, when the ADH goes to the collecting ducts, it will bind to receptors called V2 receptors, okay? Once it binds to these V2 receptors, we're going to have insertion of aquaporin 2 channels, okay, into the collecting ducts. And this is what increases water permeability. So as a result of ADH, what we're going to have is an increase of water reabsorption, okay? Water reabsorption into the bloodstream. We're going to have a decrease of urine volume. And finally, we're going to have concentrated urine. So we're going to have an increase in urine concentration. So this is just basically the primary big overview of ADH and what it does. And this is the entire mechanism of the V2 receptor. Keep in mind that this is the V2 receptor because there's also a V1 receptor, which we'll look into now. So for the V2 receptor signaling cascade, basically what's going to happen, you don't need to know this in extreme detail because it wasn't detailed in your presentation. We're going to have ADH binding to the V2 receptor. It's going to signal a GS protein, okay? So we're going to have a GS signaling cascade, basically. Adenylate cyclase will be activated, CAMP will be activated, protein kinase A will be activated. And the overall outcome of this is we're going to have phosphorylation of the aquaporin 2 channels, okay? So the whole point of this is that once the ADH binds the V2 receptor, we're going to have a GS protein cascade, signaling pathway cascade, okay, which will result in the phosphorylation of aquaporin 2. What happens then is these aquaporin 2 vesicles, they're going to fuse with the apical membrane of the collecting duct of the kidneys. And once they fuse, then water is going to move from the lumen of the tubules, okay, to the interstitium. So now we're going to have an increase of water reabsorption, and that is the primary goal of the ADH. Something quick to note, we have aquaporin 2, 3, and 4. Aquaporin 2 is what's regulated. It is regulated by ADH. We can't just have aquaporin 2 fusing alone, okay? It is regulated by ADH, but aquaporin 3 and 4, they're always present. They don't need ADH. Okay, that was for the V2 receptor. For the V1 receptor, this is located in the vascular smooth muscle. So it doesn't act on the kidney, it acts on the vascular smooth muscle, right? Here we have the ADH binding to the V1 receptor. We will have a GQ pathway signaling cascade. Okay, there we said in V2 it was GS, right? Here it's GQ. And the entire outcome of this cascade is we're going to have an increase of calcium. This increase of calcium will cause vasoconstriction, and so it will increase blood pressure. So what the V1 receptor has to do with is that when we have the ADH binding the V1 receptor in the vascular smooth muscle, okay, in the vascular smooth muscle, we have ADH binding the V1 receptor. It will stimulate the GQ pathway, which will cause, its signaling cascade, and will have an increase of calcium. The increase in calcium will result in vasoconstriction, which is going to increase blood pressure overall. And this is how it looks like overall with V1 and V2. We have the hypothalamus. It's going to stimulate the posterior pituitary. And the posterior pituitary is going to go and release vasopressin, ADH. For V2, it's going to go and act on the collecting ducts of the kidney, okay? And this is going to basically result in fluid reabsorption and increased blood volume. When it acts on V1, it is going to result in, it's going to act on the vascular smooth muscle, so on blood vessels. It's going to cause vasoconstriction, which is going to cause increased systemic vascular resistance. So we're going to have an increase of blood pressure overall. And this is how ADH acts on both V1 and V2. Okay, so what regulates ADH? So ADH is basically going to be stimulated by an increase in plasma osmolarity, okay? So when we have an increase in osmolarity, this will stimulate ADH. If we have a decrease of blood volume or pressure, if we have angiotensin 2, we can see it here actually, angiotensin 2 goes and stimulates the hypothalamus to result in the release of ADH. And stress and pain. And ADH is then inhibited by a decrease in osmolarity, which makes sense because an increase will stimulate it, a decrease will inhibit it. Alcohol also actually really inhibits ADH because you see that in alcoholics, they always have an issue of chronic urination or dehydration. And finally, ANP. Okay. And for the last part of ADH is the ADH disorders. We mentioned these in the beginning of the presentation, but we have diabetes insipidus, which basically actually has two types, which we didn't discuss. We have central diabetes insipidus, which basically has to do with a decrease in the production of ADH. And we have nephrogenic diabetes insipidus, where we have the kidneys are actually resistant to ADH. So we have ADH being produced, but the kidneys are resistant to it. So the ADH is unable to have its effect take place. So in central diabetes insipidus, we're going to have low ADH because we have decreased production. We're going to have high urine volume, and we're going to have low urine osmolarity. In nephrogenic diabetes insipidus, we're going to have high ADH because the ADH is being produced, but it's just the kidneys are resistant to it. So it's not being able to perform its action. And we're going to also have high urine volume, low urine osmolarity. And the other disorder we have is the syndrome of inappropriate antidiuretic hormone secretion, so SIADH. And in this case, we have an excess of ADH secretion. So we have so much ADH being secreted. And what this is going to cause is water retention, dilutional hyponatremia. This is important because I actually saw this in a question. You will see decrease of sodium. It has to do with this SAIDH because we have an excess of ADH secretion. We have a decrease of serum osmolarity and an increase of urine osmolarity. So in the serum, the osmolarity is decreased, and urine, it's increased. And finally, for the last hormone of this session, we have oxytocin. Okay, oxytocin is going to be synthesized in the hypothalamus, okay, by PVN and SON, if you remember, we mentioned those. Then it is going to be released from the posterior pituitary, just like ADH. Oxytocin has two main physiological functions. The first thing is that it will stimulate the smooth muscle of the uterus, okay, of the uterine lining. It will stimulate this muscle to contract during labor. Okay, so when someone is in labor, oxytocin is what will stimulate the uterine contractions. Okay, and this is very important for the progression of labor. Also, oxytocin has to do with milk ejection, or this is called the letdown reflex. So when we have, again, we mentioned this before, when we have an infant suckling on, the nipples of a breastfeeding woman, this will trigger both prolactin and oxytocin, and this is going to cause the contraction of the myoepithelial cells in the mammary glands. So oxytocin is going to cause these cells, the myoepithelial cells in the mammary glands, to contract. And this, when they contract, they're going to push milk from the alveoli, okay, into the ducts. So it's going to basically cause the ejection of the milk. So we said that, if you remember, prolactin is what produces the milk, and oxytocin is what causes the release of the milk, okay? And here I just wrote what I just said. Oxytocin does not produce milk. Prolactin produces the milk, and oxytocin just ejects it. All right, with oxytocin, we also have a positive feedback loop, and this is called the Ferguson reflex. We said that the positive loops are very rare, but we also have it here, and it will continue up until a certain point, then go back to negative feedback. When a woman is going through labor, her cervix is going to stretch. So we're going to have cervical stretch. This cervical stretch is going to stimulate the release of oxytocin from the posterior pituitary. Okay. And this is going to result in stronger uterine contractions, because we said that the oxytocin will stimulate the contraction of the smooth muscles of the uterus. Okay. And this will keep happening. So every time that the cervix is stretching, oxytocin is being released, and this is resulting in even stronger uterine contractions. And the stronger the contractions get, the more we have a cervical stretch, and the more oxytocin is being released. And this loop is going to keep happening. And we're going to have the stretch and the release and the contractions. It will keep going on up until delivery, so up until labor is over. And once it's over, then this feedback loop ends. Okay. And this is how it looks like. Basically here we have the head of the baby pushes against the cervix. This will stretch out the cervix. So this will send impulses to the pituitary gland, will secrete oxytocin. This oxytocin will then go and stimulate the uterine contractions, and the baby will be pushed towards the cervix. When the baby is pushed towards the cervix, then we're going to have again the stretching of the cervix. And this is just a cycle that will repeat up until delivery. Again, like I said, most endocrine systems do use negative feedback, and oxytocin is one of the few positive feedback systems. Actually, do you guys remember what I said was the other positive feedback system other than oxytocin? Because I mentioned one more. Yes, correct. The LH surge and ovulation. Correct. So these are the two positive feedback loops that were mentioned in all of the pituitary hormones. So some of the factors that affect oxytocin are cervical dilation, we said, vaginal stretch, infant suckling on the nipples, and emotional bonding between the mother and the baby as well will also stimulate the release of oxytocin. Inhibitors are stress, pain, and catecholamines. That's it. For the clinical applications, there's honestly not much to it, but we can give synthetic oxytocin. It's called Pitocin. Okay, I'm not sure if you need to know this, but just try to know it in case. It's a synthetic oxytocin. And what this does is that in patients who are unable to, have proper labor, this can induce the labor. If it's delayed, then it can induce it, or it can augment it. Okay. But there is risk of hyperstimulation, uterine hyperstimulation, or distress of the fetus. Also, we have an oxytocin antagonist. It's called atosiban. Basically, this will stop premature labor from occurring if it is at risk. This is the final checkpoint. please let me know if you guys have any questions because we are at the end of this session. Okay, great. And I just have one question now because I know this was a bit heavy. A 75-year-old woman complains of bilateral temporal okay. Long case. Just look at the end. A positive reaction of which of the following hormones would indicate that the tumor is of neuroectodermal origin? Oops. D. Correct. Oxytocin. Oxytocin is neuroectodermal origin. And that's all. Thank you all very much for attending. Please, if you have any questions, let me know. And feel free to reach out to me if you have any questions later on. And that's it. Oh, and don't forget to scan this code and leave your feedback, please. Thank you so much.